psychiatrists rapping about our lives and work.
This podcast is not intended to be medical advice. Any stories we use have been altered to protect identities and sensitive information.
This is intended for entertainment purposes only.
You know it!
Ow!
Welcome to the Good Shrinks. We're happy to have you with us today.
Yes, we are.
We're going to be talking about kind of a heavy subject, substance abuse.
Yeah, something that we encounter very often in the emergency department.
We see it a lot.
It affects a lot of people with and without mental illness.
Mm-hmm. In lots of different ways. You know, substance abuse, a lot of times we'll see people who have mental illness also have substance abuse disorders and vice versa.
Yeah, I think it's about 40% comorbid, right?
Mm-hmm.
So if 40% of people with substance abuse issues also have a mental health issue, and I mean, we just see it. It's a lot. It's taxing in a sense on the emergency departments at times, just how much it affects people. And you know, if they're coming to the point where they're seeing us, and I say, then it's probably a problem for you.
Yeah, and it's hard to sort out what is what, because substances can affect mood and thoughts and behaviors like mental illness can. And so if you see somebody that's coming in and they're flagrantly psychotic, running around, all these delusions, really paranoid, and then you find out that they've used something like marijuana or PCP or, cocaine, something that is stimulating them, it could be just the drug. Mm-hmm. So sometimes we have to hold them overnight just to see if they clear and if something else is going on or not. Sometimes if they have a psychotic disorder, like if they have schizoaffective disorder or schizophrenia, and then they also use cocaine, you got your hands full.
Yeah.
Trying to deal with those symptoms.
Yeah, I think a lot of times when we see patients, like, they're kind of in the throes of it, they're kind of at their most escalated, and, when they do come in psychotic, we don't know, is it related to the cocaine or the methamphetamine, the marijuana, which marijuana is not benign. It does a lot, right, T?
It's not like the old days, like the...
It's not the old weed.
This is some new stuff out there now.
Yeah, and I mean, really all drugs, including marijuana, you hear it's mixed with fentanyl, there's the synthetic marijuana.
It's a danger.
Yeah, and it just makes you so much more psychotic. Maybe we'll start a little bit with marijuana. What do you think? Since it's kind of the most benign, and I feel like society really kind of treats it as, almost really something that people just use recreationally now, right?
I think that it's something that you definitely have to be in the right mindset and the right, people use it for cancer, end of life, chronic pain issues. And some people say, like anything that comes from the earth is really natural and good for you.
We hear that all the time. With marijuana becoming more prevalent, it's legalized in so many states now. I mean, you can get it in edible form pretty much anywhere you go, and it's just so much more common and easy to get, like even at a gas station. Like, what are sort of your feelings about that? Are you for the legalization? Does it bother you a little bit? Like, what do you think?
I'm for legalization. I feel like it's liberty, right?
Mm-hmm.
You have an option of what you want to do. If you're of age and you understand the risks and the benefits, yeah, I think it should.
Okay. I see that point.
Now, if you're talking from a medical standpoint, these are my personal beliefs.
Yeah. No, that's what. Yeah, no, that's what.
Yeah, but definitely you have to be educated about whatever you're putting in your body. You have to know what you're doing, and definitely for children, absolutely not. Now I'm talking about adults.
Yes.
Grown ass people
who make their own decisions.
Make their own decisions.
Yeah. Yeah.
What about you?
I struggle with that one a little bit. So I feel like marijuana is just seen, like you said earlier on, like so many patients tell me, like, oh, I just have such bad anxiety, and they try and self-medicate with marijuana. But I mean, there's so many strands of marijuana. Some cause anxiety, some relieve anxiety. You don't know what the F you're getting out there. I mean, really,
I think when you're coming to see us, we're definitely not going to be prescribing marijuana.
Yeah.
But we see people as they come. So some people, this is where they are. So what are we doing? We're educating them about alternatives to marijuana. Like, why are you using the marijuana? What are you anxious about? Let's get to that. If we can sort of figure that out and kind of come up with a treatment plan for that, you might not need marijuana. So if you're ever using something to mask something else or to ignore or just be numb to something, that's never going to be healthy. That's never going to be something that we recommend. you always want to get to the bottom of whatever it is and not mask it with a drug or anything else.
Yeah, no, I agree with that. I think like if we can control the anxiety and it reduces the use, and that's a big win in our corner.
I feel like that's one of the reasons that people really turn to drugs is because they don't want to feel whatever they're feeling. And that ends up causing a whole lot of problems for people, if you're in denial about some things or you just haven't resolved things that you need to. So that's always part of my conversation with people who are using drugs is why are you using it? What's really going on.
Interesting sometimes, like just the poor insight sometimes people have. They're getting psychotic frequently and they keep coming back. It's like, we're past that at this point. We see from our side, it's like you're kind of past that. You really have to reduce that use. And
their brain has changed though.
Yeah,
so it's hard for them to process that. Their brain is not the same as, you or I talking to them.
There's studies that show like with teenage use, like there is some increased risk of schizophrenia, right? So it's like, is it they were already predisposed to it and the marijuana brought it out maybe a little bit earlier? Does the marijuana maybe have a little bit of a factor when it's used so early on? And I think that's something we deal with a lot. And for me, it's like, you're right, like liberty, people do what you want. But it's also when we see it on a daily basis, everyone acts like it like doesn't cause any harm. I'm like, don't really agree.
We often see in the studies that marijuana can unmask some symptoms that go on to become schizophrenia. So the sooner a child that may end up having schizophrenia uses marijuana, the sooner their symptoms may emerge. So, you have to be careful with what you put in your body.
You bring up a good point. Like a lot of times, family history is a big deal. Like if someone has schizophrenia, right, and it's in a first-degree family member, and then late teenager is sort of using marijuana frequently. We see it all the time. They come in, they're disoriented, they're paranoid, they're not thinking clearly at all. And it's at that point that we say, like, look, this is something that you have to avoid because you're losing touch with reality.
This is exactly the case that I had this weekend where there was a child, he was a teenager, and he had some kind of, it's hard to diagnose a psychotic disorder in a teenager. But he had a lot of signs pointing towards that, and he had some family history of schizophrenia or schizoaffective disorder. And he was hearing voices and seeing things. He got on a medicine regimen, did really well. He had a lot of anxiety too, got on some medicine for that. He was doing well for some months. So well that his team and his mom decided to try to take him off the medicine, which we often do. We want to give people a break and see if maybe that was just a short-time thing. So he sort of slowly has been tapering off the medicine, and then there was some kind of snafu with the pharmacy and he couldn't get his anxiety medicine delivered. So he went down on the antipsychotic medication and then completely off the anxiety medicine. And for him, he thought, I need to use some marijuana. He'd also gone sober from marijuana because he had been using that too, which is why it made it hard to diagnose him with anything specifically yet. So he had a period of time of sobriety, had a period of time where he's tapering off the meds, was doing okay at first, and then got anxious again, and then used marijuana, and then shot right back into a psychotic episode.
Yeah, it doesn't take much.
Right. If your brain is already wired to go down that path, then you start putting that marijuana on it, can make it worse.
And that's hard too, because I think back to the DARE program. So when I was in school, that was still a thing, and it was dismembered, right? Basically they found it didn't work. In fact, it may have increased kids' awareness of drugs, and so that they were using it even more. Right.
This is your brain on drugs, really?
Really?
Well, my brain on drugs.
Tell a bunch of 13-year-olds that. You're like, let's go.
That's pretty cool. What's that all about? Meanwhile, they would have been oblivious before.
Yeah, you're telling a bunch of sheltered kids about things that you can do. But it's just interesting that kind of happened, because you would think that you're learning the negative consequences, but as a teenager, you just feel so invincible. You're like, nah, nothing will happen. You know what I mean? And so it's kind of interesting for us to see it.
Until you smash cut to lung cancer, throat cancer, all the things that can happen.
Yeah. You brought up cocaine, right? So, frequently things we see is cocaine, methamphetamine,
crack cocaine.
Yeah. Well, we'll stick with the two stimulants. I guess with the crack cocaine use, we see it a lot, right? And it can kind of present like it's bipolar disorder, where they're all over the place. It can present like even with psychosis, right? Because you're just flooding your receptors with dopamine. What I find funny about cocaine or crack cocaine, sometimes among patients that I interview, is it's something that causes you to be very euphoric for a period of time. And it's expensive. It's not cheap. So a lot of times, like patients that are getting mental health treatment, they'll come in and they'll tell me they can't afford their mental health drugs. But then I'm like, well, how much are you spending a week on crack cocaine? And they'll be like, hundreds of dollars, thousands of dollars. I'm like, well, money's coming somewhere. So this is a $4 antidepressant. So pick your battles,
Because they get that immediate effect with that drug, and meanwhile we're trying to sell them something that's going to take 4 to 6 weeks to work.
Exactly, yeah, that's true.
So they get that quick fix.
And I think, sometimes we have to be careful, like from a mental health side, like, prescribing things like Seroquel, because it does have street value.
We are finding that there's street value to some of our drugs, like Seroquel, gabapentin.
I think with Seroquel, I think it's called like Suzy Q. Like I don't know exactly what it does to the high. Maybe it like takes a little bit of the edge off. I'm not really sure, but apparently you mix it.
Probably because it's a dopamine blocker, right? Maybe has part of that effect, so it's bringing you down so you're not as paranoid, maybe.
Maybe. So
and
you
can sleep.
You're almost like self-treating with it in a weird way. I don't know. It's
I mean, we're speculating. People have not ever taken Seroquel.
No.
If you look at the pharmacology of it, my guess is that it helps bring you down from the paranoia and psychotic symptoms and helps you sleep.
Yeah, maybe it makes you a little bit more level, but for some reason that you mix it together. So occasionally I do have patients that are big crack cocaine or just cocaine users in general, and they're like on 800 milligrams of Seroquel a day. I'm like, I'm not prescribing that to you.
Yeah.
But it's one of those things too that's hard, I think, from our standpoint, because when we do recommend detox from cocaine is not life-threatening, right? So sometimes they'll go and they want help and they'll go to the detox center and they'll get turned away because they're like, well, you theoretically don't need detox for cocaine. So that's kind of hard. Yeah,
it's back to the question about resources. We don't have enough resources for these very individualized cases.
Yeah.
Not everybody who drinks alcohol has the same story or resources or financial situation. Housing situation, everybody is different, and there's not enough, I think, different types of programs to meet all those needs.
Yeah.
It's just hard. We do the best we can.
Well, yeah, exactly. Yeah, we work within the system we have. And I think we do a pretty good job, but it is for us also determining. There's something called dual diagnosis when someone has mental health and substance abuse issues. If, like, let's say Betty comes in and she's been using a lot and, she's been maybe inpatient, but it's been a long time, it's like, that's just kind of our internal, I don't want to say struggle, but decision is even if you feel like she may not necessarily need inpatient, I mean, if it gives her a chance to be sober and she's seeking help, like at what point do you say, I'm going to help you?
We're always making that balance of that decision. And because our job primarily is to deal with the mental health part of it, not the substance abuse part. We don't really have programming for substance abuse programs, but we do have one unit that kind of incorporates some groups and some medical detox, I think, a little bit. But it's not a substance abuse unit. It really does. Our focus really is about mental health. But unfortunately, because it can get twisted, it's hard to know how much is due to the substance abuse and how much is due to a mental health diagnosis. So sometimes we admit just to try to detangle that and figure out what is what. And then, in the hospital, we have enough time, a few days, kind of see, are they sobering up and getting back to themselves, or are they getting even more disorganized? You have time to kind of look at that, and that's valuable for follow-up.
Yeah.
How we treat people, I feel like at the beginning of their time in the emergency room in the hospital, I think is really tied to how quickly or how consistently they follow up. If they come in and they're treated with derision or judged, or it could just be their perception of that. If they feel those things, they're less likely to follow up. So it really behooves us to try to get at what it is that they're coming for, how much of it is substance abuse, and give them education about both of those lanes, and really encourage them to keep following up, to keep trying to stay sober and get a good support system in place. We definitely have had a lot of outreach programs that I feel like have made a difference. Like one of the clinics we have that will follow up with people after they leave the emergency room. They'll make phone calls and check on them and make sure that they have lists of resources, maybe even help them make an appointment. That really, if they have a phone, this is another thing, if they have a phone, that can make a difference for them feeling, cared for and wanting to follow up with us.
Agreed. I mean, it's funny when I tell patients about that, like, referral clinic. It's like these magical group of people are going to call you and help
Right.
you, I promise.
Right.
And they
it's not like we have a little picture saying, these people are going to call you.
Yeah, it's like a picture of
this
like
is
the
a phone
Jeffersons
number.
or something, you know what I mean? But they really do. I mean, I go back and look at the notes. I mean, they're so adamant about follow-up. I mean, it's been a huge addition for us, and hopefully that's something that becomes more universal through our healthcare system, because follow-up is key.
And I said all that, and at the same time, so again, back to balance, yes, we do need to be very encouraging at the beginning, but it can be so hard.
Yeah.
Because we see that same person, and sometimes you feel like they're taking advantage of the system, that they're not really trying to get sober. They're really just trying to get out of the rain.
Yeah.
Or they're trying, or they don't even know where they are. They're just they're used to coming to the emergency. That's what they do.
Yeah.
They don't even really know why they're there. They're just knowing that's a safe place to go, and they need to come down off of their high, and that's where they show up.
Yeah, I think we're pretty good at that, is knowing when, if someone newer comes in, it's been a recent, change in, their behavior and a new addiction. You try your best to, we're going to get you in and work with you. And we do the same for everyone. I think you're right, just because of the electronic medical record. I mean, if they are coming in every third day of the week and they're really just looking for 2 meals and to sort of sober up a little bit, you get the sense of where they are. Because the biggest thing in mental health is you can't work harder than the patient. And that's a good. 100%. We cannot work harder than the patient. If they don't want to be sober, we can't make them sober. I mean, it's just the truth.
Right.
And so it's a hard, sometimes, goodbye when we tell them, okay, well, it is. Is it not?
I love it. It's a hard goodbye.
It's
a hard pass.
It's a hard pass.
We're not.
Well, no, I mean, in a good, for me, it's a hard goodbye. It's I know you need substance abuse treatment, but bye, because you're not ready. So bye.
Bye.
But no, I mean, it is hard.
Yes.
Especially when you're you need more help. But when they're not ready, I mean, addiction takes hold, and
you can't do it before
no.
they're ready.
I mean, we see the bridges that are burned, and we see the process. I mean, someone goes from let's say, a completely supportive family, then extended family cuts them off, then eventually the parents cut them off, then eventually they're homeless, and then their friends no longer give them a place to stay. Then eventually the only thing they really have is shelters, and it's and us. And it's in that word rock bottom, right? You reach that point of rock bottom, and it's when is that point for some people?
And then, right, because it's not. Even with all of that, they still want that substance. They still want that feeling. Mm-hmm. How low must you go before you
I think everyone
let that go?
Everyone has a different rock bottom. That's hard. And then in a way you see it too as their lives are in a really bad place. It's
they don't have anything to look
forward to.
This is their only recreational
sort of pastime and escape, from things that have gone on. And that brings in a whole other discussion about person's previous traumas, their life experiences, kind of why they devolve into substance abuse. Because I think that is a pattern that I'm sure you agree with, T, is there's underlying trauma. You see that, they'll even tell you things that have happened to them. And when they are sober or abstinent from drugs for a period of time, then sometimes that's the hard part. Then you're kind of looking at dealing with that. And that's the whole point of the escape of the drugs. But eventually with dependence, then you're just looking at trying to sustain while being on the drug, not going into withdrawal. It's really serving you no favors. It's just hard to see, Yeah. And talking about methamphetamine, I mean, we see the physical implications of that.
Teeth, y'all.
I'm too narcissistic, okay?
You're too cute for that. I'm too cute for that.
We're staying too cute for meth. I mean, that messes you up so bad.
Yeah.
Oh my!
Physically,
you see someone that's 40 and they look like they're 65 or worse.
It just takes your life. It saps your energy.
Yeah, 2 years. It's wild. So yeah.
Hair falling out.
No good.
It's not good. It's not good.
They're looking like a tattered mess, y'all. You don't want that.
Raggedy Ann. not want to be Raggedy Ann.
No, but we're trying on the other side. We're trying to bring you back to life, you know?
That's right.
But yeah, so I think that's one hard part is meeting sometimes people where they're at. And the other thing too is then also with family, sometimes you have those ride or die family members that will stay with them, and like this person will be stealing all their items out of their house, stealing money, and they're just trying their best to support them. So at a certain point, it's enabling. And then you have those conversations with those family members of like, how much are you willing to tolerate? Because, you know, they're not showing you they want to change. Like, do you need a restraining order against this person if they're, like, let's say, physically violent towards you? I mean, or if they're damaging your property. I mean, at a certain point, you have to kind of value yourself because they're showing you where they are. And those are other hard conversations because they're like, well, I don't want to have my family member on the street, you know? And I get that. Mm-hmm. There's not really an easy answer, but it's like maybe they're not at rock bottom because you're giving them just enough.
Good point.
Yeah. There's something I heard. I should be able to sort of say this by memory, but it's basically like if you truly love someone, you know, you realize...
Set them free.
Yeah, set them free.
I mean,
isn't that
like a special...
I was fully on board. I'm like, we're setting them free, y'all. We're just setting them free.
Set them free, free, set them free.
No, but what I was going to say is like with you enabling... you are actually accelerating their death because you are allowing them to use. So, in a way, if you truly love them, you're setting them free and broke, okay? Because that way they're not...
That's harsh.
That's harsh.
Harsh reality.
Harsh reality, but it's true. Because there's no magic wand to make someone stop using.
No.
We know that. And I know we're being lighthearted about it, but it's tough.
We basically got to know your boundaries.
Yeah.
What you can do, what you can't do. The next thing that comes out of your mouth or out of your hands, something that you're doing, should be bringing life, not death.
Exactly.
If you just kind of stick to that, then I think stay on the straight and narrow.
I mean, T, I'll ask you, have you ever had, like, let's say someone really close to you with a really bad addiction problem?
Let's see. I mean, I told you about my uncle.
Oh, yeah. That was so funny. Yeah.
He had a cocaine. He liked the cocaine.
Or didn't he call you like Reverend Dr. T, right? Dual meaning.
Reverend Doctor.
Yeah.
Yeah, I mean, it definitely is, you know, in most families, I feel like, you know, there are people who are functional, you know, are still doing things and hanging out. But yeah, I think it hits most families. Well, let's talk about some of the good things with drugs.
Okay. So let's hear about your drug experience, T.
I mean, we could. But no, there's a lot of exciting research out there now with some of the psychedelic drugs that are out there. Things like psilocybin and I think there are even some LSD studies.
Yeah.
Ketamine. Like there definitely been these exciting, because a lot of, you know, back in the 60s, LSD was just, you know, Nixon came in and kind of had this anti-drug posture, and basically because there were so many people that were vetoing going to Vietnam, and they were turning to this whole like sort of hippie culture and free love and liberty and all these things, and Nixon was like, no to the drugs.
Isn't that interesting how that always happens? Once we start gearing towards one side, the other side just rears up out of nowhere.
And they rebel, like, vociferously. So he he sort of had that whole crush the LSD. So Timothy Leary, you remember him? The Harvard, I think he was a psychologist. He might have been a psychiatrist. You know, he was definitely a pro-LSD person, and so he was talking about all the benefits of LSD, and there have never been any studies to show LSD has not caused any physical, nobody's ever died from LSD and things like that. But so since that research got stopped, and they were starting to show some promising, you know, things in anxiety and PTSD and things, and they just snuffed that all out. And it's only been recently that there's been a resurgence in looking at that old literature and trying some new trials and studies. You know, there was just a recent, FDA did not approve the ecstasy There was a study about it. They felt like there needs to be more
in the
study
VA program, right? They were looking at ecstasy or MDMA use for PTSD, and they decided not to use it. Yeah.
But even the guy who said no said, "But I'm really excited by this research. I just think it needs to be a little bit more time, with the studies." So, we're on the frontier there.
We are. When it comes to like the psilocybin, the LSD, the psychedelics, I mean, I've kind of stayed out of that a little bit. I don't know too much, to be honest. But ketamine, I do know like a good bit about, and it affects the glutamate pathway. It's a little bit of a dirtier medication, so they're not really exactly like a lot of things. Like, what is the primary mechanism of action? But studies show it's like one of the most sort of rapid ways we can treat depression.
Right.
But it does need maintenance. So
it doesn't last.
Yeah. So studies show after about 17 days, you have a decline in your mood again. So it's something that kind of needs to be used a little bit more regularly.
But these people with psilocybin, complete life transformation.
Yeah,
the journey that they go on, there are some stories too about people who had bad trips from it too. So it's not like it's just for everybody, but the research that has been shown so far has been really, really encouraging. These people are getting better.
Yeah.
Like complete, and don't need it again. Years later, they're still doing really well. So
that's interesting, right? I don't know. I don't really know what to think about it because I'm someone who just likes to be so grounded in reality. I hate to say it like that, but I just wouldn't want to take something that sends me off like that.
Well, again, they're not giving it to you like in a little bag and saying good luck.
Yeah.
Or bye.
Yeah. No, they're also doing therapy at the same time, right?
You're in a suite it's almost like a hotel room. So you're in a bed, and I've just done a lot of research looking at this.
Personal. Just kidding.
Hey, anything that'll make me feel better.
Right.
So it's very, very structured. You have two therapists, so there's never just you and one person in this altered state. So two therapists, you're in a room, either in a bed or you're on a couch, comfortable, covered up, blankets, you got headphones on, but you can hear the therapist talking to you. And they completely guide you through the whole experience. They explain, you sort of have therapy beforehand, sort of like what the experience is going to be, ask all the questions. Then you have the experience. It usually goes over a weekend. And then afterwards, you have a debriefing and kind of go through what you learned and then you have follow-up. So it's very structured. There's two people there. I don't know I think they do different dosages and then studied control people, and looked at the difference. And the research is the research.
Yeah,
people are doing
it's helping people process their trauma. I think it just allows them to sort of open up a little bit more, right? And
get to deeper parts of their brain and deeper connections about things. Yeah, it's really interesting to read what the people say that they've experienced, what they saw, and how it changed them.
Yeah, I'm sure. I'm sure it even has some effect on pathways afterwards and kind of like maybe some restructuring. Yeah, that's a little bit outside of the things that I've really looked at, but it's interesting.
I think we all need some expansion of our minds sometimes.
Yeah.
To step back and get perspective on things.
I say close my head, okay?
You're like, no! Eyes closed, hands over your ears.
Headphones. No, just the notion of being on something because I've seen interviews of people there. I don't know, with psilocybin, they mentioned they'll see a certain kind of green person. And it's a repetitive theme. I'm like, what does that mean? It's just all bizarre to me. I'm like,
right.
I'm just sort of it's just very foreign. But it does help a lot of people.
It can. I'm just excited that there are things that actually seem to be curing people.
Yeah.
We're giving people these medicines over time. Is it really curing them?
Yeah, varying in efficacy. If you maybe use it one time or over a weekend and then you process things and you feel like it's really set you free, then risk benefit, right?
Definitely with the team.
Yeah.
Don't just go get some
while you were talking
street corner psilocybin and then...
No. Well, while you were talking about this, I was thinking of, I can't remember the name of the show. There's a show with Nicole Kidman where she runs a compound.
Yes.
And I was just thinking of that while you were telling that story.
And
it's kind of that show was really good. But
that show was... Is there another season coming out?
Yeah, I think. I'm trying to remember the name. Let's see if we can find it.
It's like...
I think it was like Nine Perfect Strangers, right?
Yeah.
And who was in
Melissa
it?
McCarthy and Nicole Kidman.
Yeah, the cast was really good.
Yeah, it was really, really good. It's very strange. Like, you didn't really know what was going on.
Mm-hmm.
I love shows like that.
It feels very like California, West
they're
Coast.
on this retreat.
Yeah.
Like it's some island somewhere or in mountains or something like that. It's beautiful.
Yeah.
And all these people end up having quite a memorable time.
Yeah.
They learn things about themselves.
So, I mean, hey. I mean, again, it's one of those things, like you said, it's a risk-benefit. And if you think it's something that could benefit you, I mean, a lot of
Definitely
people...
look into it. And there's studies ongoing.
Mm-hmm.
So look up a study. Maybe there's something near you. There are lots of things in California, I know, because that's kind of the hub of the studies. But I think Johns Hopkins has something. So on the East Coast, you can look in there. So
yeah,
there's stuff going on.
That's something that this is kind of not really related to mental health, but I have friends that I know that will, like, I guess it's called like microdosing with it. Mm-hmm. So I guess it makes you feel more even keel. I mean, that's not really scientific, but it's something that I know people do. So
what's their experience? Do they feel?
I mean, they say it helps. It makes them feel more at ease and less anxious. Mm-hmm. So I don't know. I'll be honest. I've never tried it. Again, it's not really my bag. But
come to a festival.
Oh my goodness! We'll do a podcast episode while I'm having my experience.
After we come back from a festival.
Right. Me, you, and Brittany. Okay, Britney Spears. We'll be there together.
Right. Don't forget it.
Yeah, so I mean, it's interesting for sure, and it's funny. It's interesting that like sometimes with mental health we gravitate towards things because you're right. It's like we are looking for new treatments all the time, and sometimes you accidentally stumble upon them.
Well, because again, we don't really know much about how our brain works.
Yeah.
You know, we know about pathways, we know about strokes, we know what happens. You know, certain functions of certain brain, but like how this cell talks to this cell and makes this decision to go to this cell and not that cell. We're not to that molecular level yet. I mean, again, hats off to those researchers out there that are trying to get those answers. But I mean, I think it's a I don't want to say it's a crapshoot when we use these medicines because it's not. It really is based on science, but we are making educated guesses about how these things interact. Mm-hmm. Meanwhile, these substances like psilocybin or LSD go directly to these centers and make immediate impact and change something in your chemistry so you have a different perception. That is something that should be explored. What is that doing to your brain? How is that, those pathways opening up, how does that help you see the world differently and maybe see yourself differently so that your mental illness is better understood? And
maybe with time, like, you know, if it's efficacious, like, we'll see it. The data will show that it's helping. And if not, then we'll kind of
we'll see that too.
Yeah, exactly. Yeah. I think we'll see.
Stay tuned.
But yeah, I think kind of the biggest substance that we see is alcohol, right? Mm-hmm. And that one is something that is very prevalent, very comorbid with all of our mental health diagnoses that we see. And that's a tough one because
it's not illegal.
It's not illegal. It's permeant throughout our society. It's something that we all
easy to get.
Use at some point. I mean, even I've been, like, when I was in med school, I remember, like, like, you know, you ask patients, like, oh, this was before I even went into psychiatry, just med school doing general stuff. I'd ask patients, like, oh, how many drinks do you have a week? I'd be like, oh my God, you have 4 drinks a week? Meanwhile, on the weekends, I would have, like, 9 a day. You know what I mean? Like, on the weekends. So, I mean, like, literally, it's just, you know, I didn't have a predisposition. Like, I never had a problem with alcohol, but it's just funny how we kind of, in medicine, it's, like, very faux pas, you know? But, I mean, our patients struggle with it, and when you're using it daily, and I always say, once you reach the point of coming to an emergency department, whether it was due to conflict with your spouse, a DUI, missing work, I mean, those are all eye-openers and reasons, like, you need to start looking at this being a problem, right? And, you know, it does have a long-term impact on your health, big time.
This is the thing. Yes, it's affecting your mental health. That's what we look at, and that's what we do. But it's also affecting your liver, and you need your liver to survive anything. Yeah. It breaks down, it metabolizes things in your body so that you can use the energy or use whatever the metabolites are to function. You need your liver to break medicines down. You need your liver to just do lots of things. And so if you don't have a functioning liver, you're not going to survive.
Yeah, yeah.
So regardless of your mental health, which, is important, you need your physical health. You need your liver to be working.
I mean, we see it, often, like, I think it's around, like, 30% of your liver. Once you go below that, then you really start
hard
having...
to regenerate it.
Yeah, your liver only regenerates so much, and that's when you really start getting the physical manifestations. I mean, I remember in consults, like, I saw all the time individuals that have, like, hepatic encephalopathy, they call it. Like, basically your ammonia builds up in your body, you get really loopy, you start having hallucinations, and then they call us, that's...
So not only are you having psychotic or mental health symptoms when you're intoxicated, but you can also have them when you're coming off the drug.
Yeah. And the thing about alcohol withdrawal is it is deadly, so...
Seizures and death.
Delirium tremens, hallucinations. So we take it very seriously. Actually, the saddest thing, one of the saddest things I ever saw in my medical training, again, this was back in medical school, is... this guy was probably in his late 30s. He didn't even hit 40 yet, and he was super thin, and he was breathing really heavily, and he was trying to live. You could see it, and he was as yellow as Big Bird, literally, and he's just gasping because as the
fluid
ammonia, builds up in your body, it's like you try and compensate, so you breathe faster and faster, and he looks so uncomfortable.
Blow the CO2 off.
Yeah, exactly. So you're trying to basically make your body less, I guess, basic, So the mom was at bedside. She had a little Bible. She seemed honestly the sweetest lady, and she just turned to all the med students and she was like, I want you guys to see this. Alcohol has killed my son. And she's like, she goes on this thing about how she tried so hard to get him help, and she's like, alcohol is killing him. And we watched him pass away over 2 or 3 days, and it was the most depressing thing. I think one of the most depressing things I experienced.
That is so sad.
Especially because the mom was there, and
Did
she was...
say that in front of him?
Yeah, right there. I mean, he was at the point where he was kind of
delirious.
Just a little bit, yeah. I don't think he was really hearing much of what she was saying, and she was almost using it as a teaching moment for us, but...
And delirious is the condition when you are confused and disoriented, usually from some kind of alcohol or metabolic derangement. So you just get really, really confused. We call that delirium.
Yeah. And so at that point on, I was like, man, okay, only once a week.
Bottom line.
Yeah. But, because also, right, we know alcohol is a depressant.
Right.
It depresses your central nervous system. Everyone knows that.
Yeah, some things bring you up, like meth and cocaine, stimulants.
Some things bring you down.
And cocaine can bring you, coming off of cocaine is probably the worst depression I've heard people say that they feel.
Oh.
Those couple days after coming off of cocaine.
Because your body's just making no dopamine. You're probably just
You're completely depleted.
Yeah. You're just probably just like a log. With alcohol, I mean, we really do the best we can because a lot of people come in and you can tell they're trying so hard to stop drinking. And it's just so prevalent in our society.
What are some things that we use to treat people who have alcoholism?
So when it comes to medications, we do use them. There's some, I would say, fluctuations in efficacy. I often try to use gabapentin because it's shown to help with alcohol cravings, decrease anxiety and alcohol withdrawal symptoms as well. So I feel like it takes the edge off and can help people. Naltrexone we use, which is actually like an opiate antagonist, and so all that means is basically you don't get the euphoria or the pleasure from drinking. And really, naltrexone is just kind of it's like an antioxidant in a sense. There's not really many side effects from it, so I try to prescribe that pretty regularly.
The studies show with naltrexone that it increases the length of time to your first drink.
Interesting.
So it stretches it out. So if you relapse, it takes you longer to relapse than if you don't use naltrexone.
Yeah, and even sometimes, this is a little bit off topic, but like let's say people that self-harm, right? They'll mention having some euphoria from the self-harm, so also that kind of takes that away. So I
have seen that being used more for self-harm.
Sometimes I honestly forget to use it. I should probably think about it a little bit more for self-harm because we think about.
That's why we talk about it.
Yeah.
Good job.
There we go. Yeah. And then, is there anything else that you really like to use for alcohol too?
I mean, there are things that I remember from residency that I have never prescribed, like Antabuse.
Yeah.
Which is this medicine that you take and it will make you deathly sick. Not
you
not
drink.
really deathly, but you will throw up. You will be nauseated
If you drink.
if
yeah.
you drink on it. So it's sort of like a deterrent that way. But I haven't used that since residency.
Yeah.
People get really sick and then they're mad at you.
Yeah.
Even though you tell them that this is going to happen.
Well, and I've had people say they've like thrown it up or worked their way around it. Like if they really want to drink.
If they really want to drink.
Some people will
they're
drink
gonna
through
drink.
it. So, I mean, I don't mind anti-abuse, but I feel like they're almost not quite ready to stop sometimes. And
Then for some people who don't like to take a pill every day, there are injections that you can get, sort of like the injection of naltrexone.
yeah, Vivitrol, I think is what they call it. Yeah.
Yeah, there are things out there. So people have been trying to find ways to help these folks.
Really, the studies show that AA is so important.
Yes.
I mean, if you have
Support.
the accountability, like, and people who understand what you're going through, and it's a good support network, then that's worth its weight in gold.
Absolutely.
Having the proper sponsor, I think that's really the biggest thing that sometimes people downplay. I hear a lot of like, oh, it has religious undertones, or there are
It's
people.
not for me.
It's not for me, but it's like really. I mean, if you can dedicate and find a good group, then it will change your life. You know.
And for the family members of those with substance abuse problems, it's good to check out Al-Anon because they help you with making boundaries and sort of holding yourself accountable to not enabling your loved ones.
And it gives you a support network also.
Yep.
So I think that's the biggest thing. And then really, we have a few detox centers you have to refer often because 3 days of not drinking, you're at your highest risk of seizure. So if you're someone that has been drinking a good bit, something to pay attention to. I think one thing, too, about drinking that's interesting is individuals that are like on the bipolar spectrum, sometimes they'll start drinking a lot and then develop mood instability and mania. Sometimes it's like, are they getting manic? And then that increases their desire to drink.
Well, we just saw that article that said that the people who have mental disorders, that their brain is different so that the drugs affect them differently and makes it more likely that they will use that drug, whatever that drug is. It could be alcohol or marijuana or any drug. So there's something different about their brain from the get-go because they have the mental illness that makes the drugs affect them differently.
Well, you see individuals that are alcoholics or have a predisposition towards drinking, there are differences in how they respond to it. Like, they tend to get more energetic. Where a lot of people who get tired on alcohol, they almost seem to kind of thrive on it to some degree. I think there are some biological differences in individuals that have alcoholism.
That's why it's important not to just put people in a box. Like when we're getting ready to go see a patient, there's just a piece of paper in a slot for us to pick up. And so we'll get a snapshot from the nurse's note what they're here for. And it's very easy to sort of put them in a category. Already halfway write your note, you know what you're going to do. And then you go in there and find out it's completely different. Or there's something that, that you need to dig into a little bit more. So it's important to not have the categories already judged in your mind about what you're going to do.
Yeah, I agree. I mean, sometimes these individuals, they resort to wild things. I mean, drinking mouthwash. I mean, wherever they can get a form of alcohol.
Everything. I have seen mouthwash. I've seen people drink the stuff out of the hand sanitizer.
Oof.
I mean, everything.
Yeah. I have heard of the hand sanitizer. There's probably a few other things. One thing, too, about alcoholism is there's a huge genetic component that often we don't talk about. They did like an identical twin study to see of things that are most common between both identical twins. And number one was alcoholism. Wow. It was even higher than eye color. So I guess like one set of identical twins like had like one different eye color.
Is that identical?
Well, I think it was related to a trauma. I think something happened.
Oh.
So I guess they counted against it for some reason. But like alcoholism was the highest thing. So I mean, I do think that there is a huge genetic component. We don't realize quite how much it can impact in families.
This is a little off topic, but you brought up something that's one of my favorite, most intriguing things is studies of twins that grew up apart.
Oh, yeah.
I love any kind of study that does that because the correlations that they find, you cannot explain from they just grew up together and they did the same things and they influenced each other.
No.
And there's still so many similarities.
I saw a video, it was basically like the spouse had the same name. They named their dog the same name.
Lived on the same street.
Yes.
Had the same job.
I
drove
mean,
the same car.
so
Married the same
kind of
the
person.
spouse.
Yeah.
With the same name.
So interesting, right?
Yeah.
I mean,
what is that?
Yeah, I don't know.
So interesting.
What would it be like to have a twin?
Yeah, awful about that.
The twin telepathy or whatever, you know
They
what I
have
mean?
contests for twins that are the most alike.
Oh, that's
And
interesting.
there's like one little, these guys, I think they're in their 80s now, have won like several times. I think they were in the Guinness Book.
Oh my goodness.
For most alike. And they had this whole list of things that they were just alike about, and they were so cute. And all I could think of is if one of them dies first, what is the other one going to do? You've been with this person your whole existence.
Whole life.
Existence, even.
Yeah.
Like before you even out here, you were with that person, now they're gone.
Mm-hmm.
Okay, we're completely off topic.
I
but
know, that's okay.
just-
No, I mean, it's interesting. But yeah, because
Yeah.
there's nature versus nurture. It's always an ongoing discussion. I was just thinking one of their substance, I guess we'll save this one for later because the episode's getting a little bit long, but we didn't bring up like opiates.
This is substance abuse plus.
Plus. Yes. Opiates, heroin. So we'll come back. I think maybe we'll do another episode on that.
I mean, because it's such a crisis right now. We probably should
know.
spend more time on it.
Yeah, like we can talk about fentanyl and maybe do a little bit of a deeper dive on those.
And the
But-
treatments for that.
Yeah, because that actually, from an emergency department standpoint, is kind of the scariest for us when someone comes in. They have an altered mental status. They're not responding.
Because
and
they
you-
could just fall down and that's it.
Yeah, and you assume they took like fentanyl or some kind of opiate, and that's always hard. You
It's
know.
important to have Narcan somewhere in your house. Just for, you never know, somebody could come over.
Yeah.
It's just good to have it. Kind of like a defibrillator or
Yeah,
a
just-
fire extinguisher.
Just in case.
Just for safety, yeah.
Yeah. You know, I guess to close the show, T, I was thinking about this. So, in our intro, we say we're two psychiatrists rapping. So
Where did that come from, Steve?
Maybe we should disclose now. When we were starting this podcast,
Yeah.
T and I were coming up with names, and we thought we came up with an original name.
Yeah.
Turns out we did
loved
not.
it. We loved it. We were just like all into the
literally
fantasy.
We were in the fantasy of calling this podcast Shrink Rap.
Right.
And it turns
That's
out
a cool name, right?
yeah, because get it, shrinks rapping.
Yeah.
Well, apparently we're not original at all. There's
At
like
least regarding that.
yes, regarding that. Otherwise, we are. But we literally like there's like 2 or 3 other podcasts with the same name, and one of them is actually very well known. So I was
we
like,
did not want to offend anybody.
we are going to get sued if
Right.
we use this name. And then on top of that, like
before we could even do anything.
we were going down the rabbit hole of like we had shrink wrap down here.
Yeah, we were gonna do an intro picture with dressed in shrink wrap.
Yeah, we were gonna have ourselves combined in shrink wrap around our heads, and like we even
like the James Bond, like
yes,
back to back.
We even had I actually still have it right here, shrink wrap that we were gonna create noises with.
ASMR.
You know, so a little bit of a hi,
Welcome to Shrink Wrap.
but it's actually the good shrinks.
Yes, it's the good shrinks. Let's make that clear.
So I just think it was funny. I feel at some point we have to share that story.
Yes, good job.
Yeah, because it's really funny. And now no one will listen to that intro ever the same.
Thanks so much for spending time with us and listening to us debrief and let these feelings out. We appreciate you taking a journey with us.
All you family, friends, all 3 of you.
That's right. Hey, we do it for the people.
We do it for the notoriety.
Fame.
Maybe Brittany's listening. Who knows?
Who knows?
Anyways, well, all right now.
See you next time.
Bye-bye.
Bye.